Okay, welcome back, Stolen Valor Medicine. We are now into damage control resuscitation. Thank you for joining me. There's no other way to say it. This one's a beast. I got like 10 pages of show notes, but this is going to be awesome. This is a capstone lecture, a capstone video for everything we've learned so far in our asynchronous curriculum or on this channel. And so I'm really excited to get into this. This is really getting down to looping in everything we've learned into like, all right, we've learned March. We've learned our principles of resuscitation leadership, our principles of how we structure resuscitation. Now, how do we actually what are we looking for the points? How do we make decisions on what kind of blood to give people, how much to give people? How do we do the walking blood bank? Sort of. This isn't quite a walking blood bank lecture. And then how did we get into the principles of DCR and how did that start? Okay, so let's get into it. We're going to talk about the history of DCR. Like I mentioned, the goals of DCR. Who are my friends in DCR primarily? And then the big chunk of it is how to do DCR good. All right, disclosures, as per usual, I just do this for fun. Okay, I do this for fun. I'm in my backyard. I have no sponsorships. I have no financial disclosures. I'd certainly love some. If you got anybody who wants to pay me to sell their stuff, I totally will. I don't speak for the DoD or the JTS. That's the big one. And then the super big one is all this stuff is just like my opinion. It's my interpretation of other people's opinion, and it's the interpretation of the experiences that I've gone through, which may or may not be accurate, and have my own biases certainly. So do your own research. All right. DCR, damage control resuscitation. That sounds cool. That sounds pretty sick. What does that actually mean and who came up with that? These guys came up with it. Rotondo et al. In the 1993 Journal of Trauma is the first reported use of damage control in reference to trauma care. Specifically, these people, I'm going to go to the notes because, again, I got a lot of them here. Patients underwent surgical management rapidly after trauma to obtain hemorrhage control / contamination management, and they were transferred to the ICU for further resuscitation to restore their physiologic norms, improve trauma-induced coagulopathy, hypothermia, and acidosis prior to a repeat trip to the OR for definitive repair. Essentially, what they were doing was stopping the bleeding, got them less sick by resuscitation, resuscitating their normal physiology back into them, back to baseline, and then they returned to the OR for definitive care. That's definitely what we do now in the battlefield and in the echelons of care in the military, and what they do, certainly at civilian trauma centers and all that kind of stuff. Okay, so they're the first people to write it down, basically the first people to put it in words what they were doing. Damage control surgery. That being said, damage control surgery goes back a lot further than this. Okay, damage control surgery probably goes a little bit to World War One is when it was really first started to be applied. This is a picture in the operating room at AEF Mobile Hospital, number 39 in France during the war. And so this is the first war where people really got brought close to the battlefield. So they moved surgeries up as far forward into the battlefield as they possibly can. We talked about that in, I believe, the head trauma video. Great book on that is The Great War and the Birth of Modern Medicine by I believe a gentleman named Thomas Helming, something like that. Really great book. But DCR probably goes back to World War One. There are certainly cases of blood transfusion, tourniquet use, surgeries from trauma, battle, whatever, going back hundreds of years. But this is really institutionalized systemic approach to DCR is most likely the first time in World War One. This is probably in the Pacific Theater. The picture that I found did not give it credit to where it's from. But blood transfusion in World War One is quite cumbersome. It is around. Blood typing had been done already. The equipment for blood transfusion had been done already. There was like some surgery, some vascular surgery. They basically graft catheter into one person's vein or artery into another person. It required like lots of long suturing. It was very delicate and problematic, not really equipped for the battlefield. But blood transfusion was a thing during World War One. It was just rare, secondary to it being quite cumbersome. Fast forward 20 years in World War II, now millions of units of blood are donated, transfused. The Americans primarily are resuscitating with plasma. I believe that's what is seen in this picture. This is probably in the Pacific Theater, and all the Joes have their shirts off. And then, God, that'd be sick to be a doctor during that time, except for the massive carnage. Just roll around with your shirt off, resuscitating people with just like fulminant malaria in your own body. But man, what a nightmare. So Americans primarily resuscitated with plasma. The UK and the USSR, the Soviets, primarily resuscitated with whole blood. So by the time we fast forward 20 years, lots more blood being used. Okay, have you seen this article before? Like we've seen this article a million times. All right, landmark article, Brian Eastridge, Mabry, all those guys, death on the battlefield. Okay, it showed that most combat deaths are pre-hospital, and then about 24% of those pre-hospital ones are potentially survivable injuries, mainly due to hemorrhage. So this is a massive jump in terms of the science of DCR. We're finding why are people dying and where are they dying and what can we do about the ones that are preventable. Okay, so in World War One, we're moving people close to the battlefield. World War Two, we're doing lots of blood. Vietnam, we are continuing to reduce the mortality, the case fatality rate in Vietnam as well, but people are still dying of just preventable death from pre-hospital extremity hemorrhage. And then so Eastridge et al. In this paper, landmark paper, say that we need to move forward, and this is the reason why we're dying. Okay, this one, Fisher Shackelford, I believe the head of the former JTS trauma surgeon. Frank Butler's on there. He's a TWC original dog. Jennifer Gurney, also Cotwall on there. All the original people are on this one too. This is from JAMA in 2017. So this is along our echelon of how are people dying for DCR and how do we do better at that. And then we'll get to the actual CBGs. But JAMA 2017, they looked at a retrospective review examining the timing of pre-hospital blood transfusion in U.S. combat casualties, basically from 2012 to 2015. They had shock or at least one proximal limb amputation, shock or one proximal limb amputation, and the effects on mortality of that pre-hospital blood transfusion at 24 hours and 30 days. Okay, so mortality, the ultimate patient-centered outcome. Okay, we don't care how many days they're in the ICU. We care if they lived or died. All right, if you're the patient, you care if you live or died. You don't care about the cost. You care if you live or died. Those are patient-centered outcomes. And so here's what they found. Should we be giving pre-hospital blood to combat patients? If we are giving blood early, is that better for them than if we wait until they get to the hospital? All right, 24-hour mortality in the pre-hospital blood transfusion group was 5%. The control group, those who did not receive pre-hospital blood transfusions, 19%. So massive increase, okay? So it sounds like pre-hospital blood is good. Let's get to the 30-day mortality in pre-hospital blood group 11, 30-day mortality in the control group, those people who did not get pre-hospital blood, 23%. This looks great, right? Stacey Shackelford, props to you. This looks like a great trial. Everything is pointing to people need to get pre-hospital blood as soon as humanly possible. All right, bring it on the helicopter with you, bring it out on the X with you, get pre-hospital blood. But there are some critiques to this trial. Nothing comes without critique, of course. It is retrospective. Retrospective trials are, observational studies are prone to bias from various reasons. Mainly the data could be corrupted. You can't get the data. The data is not as detailed as you want it to be. That kind of stuff. And then the biggest critique with this trial is really that like very few people got pre-hospital blood. So the trial looked at 502 patients overall. I should say not really a trial, it's a study. Looked at 502 patients overall. Only 55 of those people actually got pre-hospital blood. So just like a little more than 10% of them actually got pre-hospital blood. So there is kind of a problem with that. But even with, you go to war with the data that you got. Okay, so I think this is good enough to say that does this, pass the smell test or not? This makes sense conceptually. Okay, I'm bleeding to death. You give me the thing that I'm bleeding earlier versus flying me all the way far away to the hospital, and then they give it to me. So if I'm less sick by the time I make it to the hospital because I've had some of the juice pumped back in me, that seems to make sense conceptually, even though this is, a pretty big paper, but just based on only 55 patients that actually got the intervention. Okay. Um, Isaac Newton, if I've seen further than others, it is by standing on the shoulders of giants. That's what we're doing. Okay, that goes back to the 1993 article that first discusses damage control, the battlefield of World War One, where they moved the surgeons close to the battlefield and started doing damage control surgery. World War Two, where we're having more of a blood first resuscitation strategy, and then Eastridge, Cotwall, Butler, Gurney, Shackelford, all these people who are basically dedicating their entire lives to improving mortality on the battlefield. And so those people and the ones who came before us have consolidated this thought process behind DCR and emphasized the importance of rapid hemorrhage control, blood product transfusion, and then the restoration of normal physiology as quickly as possible in patients with traumatic injuries to improve their chances of survival. That is what DCR is, and we're only able to talk about it because people before us, again, dedicated 20, 30 years of their life to figuring it out, and hundreds of patients. Let's get into it. We're going to go through a bunch of CPGs. Okay, this is like the DCR CPG, the DCR in the prolonged field care environment, some of the whole blood CPG, some of the blood transfusion CPG. This is a lot of them in one. And this is a quote that's straight out of it. Okay, what is the goal of DCR? The major principle of DCR is to restore homeostasis, prevent or mitigate the development of tissue hypoxia, oxygen debt, and burden of shock, as well as coagulopathy. This amounts to preventing, quote, blood failure, end quote, specifically with a goal of restoring blood functionality, improving oxygen delivery and tissue perfusion, reducing acidosis, preventing fibrinolysis, reducing coagulopathy, protecting the endothelium, and reducing platelet dysfunction. A lot there. Okay, there's a lot there in that, but that is the overall goal. We are taking all the things that happen to a person physiologically in trauma and attempting to reverse them with our resuscitation strategy. Okay? How? How are we going to do that? That sounds like a freaking big order. So how we do that? There's like 8 steps, 9 steps. Aggressive hemorrhage control, blood-based resuscitation strategy, avoidance or limited use of crystalloid. That's lactated ringers, normal saline. Don't use Hextend, all that crap. Selective use of hypotensive resuscitation. We're not resuscitating them to a blood pressure of 140. Okay. Correction of coagulopathy and acidosis. That one's, we'll get into that. Avoidance of hypothermia. Expeditious evacuation to DCS capable facility. That is a damage control surgery capable facility. Okay. Lots of caveats to that in the next VSCO environment, but that's how you do it. All right. We'll get into all those. Favorite meme of all time. All right. This is in my Resus from Hell lectures that I do with my residents. The fundamentals are not basic, they're essential. You can only become good at something if you are good at the boring thing. So the fundamentals are not basic, they are the essential building blocks of your resuscitation life. You cannot become a doctor unless you know the basics of chemistry. You cannot become an engineer unless you know the basics of physics. You cannot become a teacher unless you learn the alphabet. So the fundamentals are not basic, they are critical building blocks of your life. And your patients need them. So focus on the fundamentals. Who are my DCR friends? Okay, I'm gonna move my face up and out of them. Might be good. Who are my DCR friends? Who are my damage control resuscitation friends? Who do I need to look for during this? It's basically a trauma surgeon. Trauma surgeon is really who you're looking for. They are your best friend in damage control resuscitation and damage control surgery. One, they're experts in trauma. Okay, certainly if they're a fellowship trained like trauma fellow, yeah, they're definitely experts in trauma. And then secondarily, they do things that you can't if you're not a surgeon, right? Trauma is a surgical problem. As an emergency medicine physician, I do not have a problem saying that. I'm super good at things that a trauma surgeon isn't, and they're super good at things that I'm not. And the main thing they're good at that I'm not is cutting people open and fixing their bodies that are broken. All right. I have a metaphor here which I think works, so give me a little leash on this one. But this is the smoke and mirrors versus the magician metaphor that I came up with several days ago. If you've ever seen a magician, during the magic show, there is smoke, there is laser lights, there are loud flashes and bangs, okay? And then there is the magician themselves, okay? If the magician himself was up there without the smoke and the mirrors and the flashes and bangs, he would be much less dramatic. And the magic that that person is doing probably would not work that well. So although the smoke and the mirrors and whatever is not the sleight of hand, it is not the years of training that the magician did, it is vital to the show, okay? And so I view myself as an emergency physician, experts at the resuscitation of the undifferentiated critically ill. But when it comes to trauma, I am the smoke and mirrors portion of that team because we know what's wrong with them. They're probably bleeding to death. And we know how to fix that. And I can do all that stuff, right? I can intubate the patient, I can resuscitate them, I can prevent coagulopathy or reduce the coagulopathic burden, I can prevent hypothermia, I can treat TBI. I can do a lot of stuff. I can do most stuff. What I really can't do is go into the abdomen and stop their bleeding. What I really can't do is like shunt an artery. I really shouldn't be doing like any traumatic amputations. I shouldn't be doing, all sorts of ectomies and otomies like a surgeon does. And so the surgeon is the magician. I'm the smoke and mirrors doctor. Together, we make a great team and we really do the magic of resuscitation. They're both needed when it comes to DCR and DCS. It is the resuscitation and the surgery part. So I think take pride in being a smoke and mirrors doctor or a smoke and mirrors medic or a smoke and mirrors nurse because you're just as important as the person who actually does the surgery. If you give a surgeon a person who's not been resuscitated, they can be the best surgeon in the world. Doesn't matter. They're going to die on the table because they've not been prepared enough for surgery. You haven't resuscitated them to a stable enough point. All right. And then here's what trauma surgery is like. Trauma surgery is stabbing someone back to life. There you go. All right. This is my opinion. Opinion alert. Survival depends on pushing the highest standard of care to the lowest echelon of care. I fully believe that. I fully believe that down to my bones. That is literally why this channel exists, because I want to push the knowledge that myself and others have learned and those who've came before us down to the lowest echelon of care, down to the lowest Air Force medic, the most junior Army medic, the most junior Navy corpsman. I need to push this knowledge down to them because you are the people touching the patient first. The first person to touch the patient are the most important, in my opinion. Again, if you bring someone who has been an hour after their sickness has sickened them, after their gunshot wound, their IED, whatever, and they're unresuscitated, our odds of saving them just go way down. I mean, you looked at the Shackelford paper just a couple of minutes ago. The earlier you start resuscitation, the better. And so I think we need to push that down to the lowest level of care. And so that's why we're here. That's why we're talking about it. DCR principles need to start at the point of injury. I'll go to my grave believing that. Okay, let's keep it moving. Here's a big chunk, how to do DCR good. There's a whole big blood section in here, so don't worry, we'll talk about that. This is how you do DCR good. This is straight from the CBGs. This is most of their section. There's a documentation section, which I don't care about that. You need to document. That's really important. That's basically how they do these retrospective reviews if you don't document it. So you do need to document real good. But I'm not going to talk about that. Your NCOs can talk about that. Your senior medics can talk about that. Recognition of patients requiring DCR, damage control, resus, hemostatic adjuncts. We're going to talk about some bullshit in that one. Monitoring endpoints, small human considerations. Those are pediatric considerations. And then expectant management. We're going to finish up on some sad ones. Pediatric trauma and expectant management. Okay, so recognition of patients requiring DCR. This is going back to the beginnings of your training, right? Your how to recognize a sick person and then what to do about it. So we start with the vital signs or physical exam abnormalities. Okay, if they're sick, like their blood pressure is low, their heart rate is high, the closer those numbers are to each other, the worse. That's called shock index, good marker of occult shock. Okay. And so heart rate over systolic blood pressure, the closer that gets to 0.9 and higher, the sicker they probably are. Okay. Clinical signs of shock. What does that mean? It means they look sick, dude. Like they've got cold, clammy skin. They have delayed cap refill. They have absent or weak peripheral pulses with present central pulses. They have altered mental status without evidence of head trauma. Okay, so they're ill appearing, and their vital signs say that they're ill. Those people might need DCR. Then also injury pattern. Okay, those things, those vital signs could also be seen as someone who has septic shock. So they're dying of pneumonia, they're dying of urosepsis, dying of cholecystitis, and they never went and got evac'd. Okay, matters. So the physical exam, the injury pattern matters. If you have an above knee amputation, especially with pelvic injury, if they stepped on an IED and they have an amputation, super high chance they got a pelvic injury. So just assume that. Okay. Certainly multiple amputations, I hope, would raise a suspicion that the person is going to require some damage control resuscitation. They're damaged, dude. So they need to be resuscitated. Penetrating trunk or abdominal trauma, wide variation there, right? If I'm shot in the upper, chest, that's trunk. Certainly, if I'm shot right in the middle of the box, that's bad. But those are probably different types of injuries. And uncontrolled truncal or junctional bleeding, they're bleeding to death in their trunk, and you can't stop it. Those are obviously going to require some DCR. Cool. I got imaging or lab abnormalities. This will depend, right? So some of this is from the prolonged field care CPG. Maybe you have some labs. Maybe you have some pictures that you can be taking, right? Maybe you got an ultrasound. Big ultrasound guy. I'm not an ultrasound fellow. I'm not a nerd, but I do like ultrasound. I use ultrasound every single day in my clinical practice. I'm not sure a day has gone by where I've not used ultrasound. So bring an ultrasound with you. Okay, get that butterfly, get that GE, whatever that one's called. That one's good too. You got a positive fast exam. Okay, they're bleeding inside their belly, and you can see it with your fancy ultrasound crystal machine. Okay, that's bad. They need to fix that. They're acidotic, pH less than 7.25. That's even more acidotic than acidotic. Okay, that's starting to get into the more serious acidotic realm. Base deficit greater than 6, lactate greater than 4. Previous version of the CPG said 2.5, and then INR greater than 1.5. Will you have INR? I don't know. That's a sort of a niche lab, but you might have it. There are point of care INRs available. Game of Thrones, I think. You're bleeding out and you're going to need a transfusion. What's your blood type? Be positive. I am trying to be positive, but you're bleeding a lot. Okay, I like that. As you guys know, the memes are for me while I build these. Okay. Hemorrhage control. We're going to attempt to stop bleeding at all cost with TCCC approved methods. We're not going to go off the reservation and do something stupid with the improvised tourniquet or anything unless we're trained in that. We're going to use TCCC approved methods. Tourniquet use. These are covered so flippin' extensively in previous videos, and by God, I hope this is covered in your training. Tourniquet use, which I think I spelled that wrong there, but tourniquet use covered a lot. Use your tourniquets. This is the 2 and 6 hour rule tourniquets. I initially wrote 2, 4, and 6 hour rule, but then I couldn't find data for the 4 as much, kind of mixed data. Basically, 2 hour rule, right? So you want to get that tourniquet converted in under 2 hours. That's the goal. Okay. In most places, that's probably feasible. If the person has an amputation, probably not feasible. Okay, don't do that. But there, in the other videos, I talk about rules for tourniquet conversion. Okay, so try to tourniquet convert your people in under 2 hours. Initially, the 4 hour rule was after 4 hours, you're probably going to start. You may develop some neuropraxia, which may or may not, which is basically injury to the nerve, often reversible, but sometimes not always. I don't really care about that as much. If you cannot convert the tourniquet because they're unstable, fine. You can't convert the tourniquet. You know, damn the nerves. You know, it is what it is. But you really got to get that person to a surgical capable facility, and you really got to start to be experienced in terms of reperfusion injury and how to treat that, you know, with IV fluid, potentially calcium, you know, among other things. And then the 6 hour rule is if a tourniquet's been on for 6 hours or more and you receive a patient, you should probably not be turning that tourniquet down unless you are at a surgical capable facility and a facility that's capable of ICU level care, certainly in terms of reperfusion injury, because that person is probably going to lose that limb and they're going to have massive reperfusion injury after you take that tourniquet down. It's very valuable that you do not just take it down and cause massive reperfusion injury, which causes hyperkalemia, really, you know, it could be fatal, cardiac arrhythmia secondary to that. And if you don't have the stuff to treat them because you're treating them out of a fanny pack or a backpack, I'm sorry for your friend, but they may just need to leave that tourniquet on and basically condemn them to a limb amputation versus condemning them to death from reperfusion injury. And so 2 hour rule is a hard one. Convert that thing in under 2 hours if you can. 6 hour rule, also a hard one. Going to be even harder emotional decision to leave that tourniquet on, but sometimes you need to leave that tourniquet on to save their life over limb. Okay. Wound packing, control junctional hemorrhage. Talked about that ad nauseum. We're not going to go into that further, but control bleeding, control the bleeding, control the bleeding, stop the bleeding, stop the bleeding, stop the bleeding. There you go. Resus, famous Rolo picture. Okay, blood first resuscitation strategy is how we resuscitate people. How do we pick and choose? There are some priority decisions when it comes to blood products. There's some key component info like how long is blood stored? What do I do about that? What kind of product am I gonna have? What product am I not gonna have? Some donor considerations, and then we'll talk about calcium. Some of these we've talked about ad nauseum. Some of these are kind of brand new. But this is the famous picture from Ranger Regiment. All the Rangers do Ranger O Rolo program, O low titer O program, whatever it's called. Okay. All right, priority product. Okay, this is not my priority. This is not my opinion. This is what the CPG say. In this order, this is not arbitrary. Okay, fully transfusion transmitted disease, tested, cold stored, low titer O, whole blood. Stored plasma PRBC platelet ratio of 1 to 1 to 1. Okay, and then type specific whole blood, also known as fresh whole blood, from a pre-screened donor. Pre-screened donor, remember that. And then PRBCs or plasma in a 1 to 1 ratio. Sorry, PRBCs and plasma in a 1 to 1 ratio. And the next one is plasma or RBCs alone. RBCs are red blood cells, if we're not tracking that. And then PRBCs, packed red blood cells, same thing. Sorry, I should not use them interchangeably like that. They are the same thing though. Plasma or RBCs alone. I think the CPGs actually give a little credence to plasma over RBCs. they're both important. It's a weird situation where you have plasma but not RBCs, so I don't know. I don't want to speak to that, but it's possible you could substitute freeze-dried plasma in or these other ones for it. They're essentially equivalent. And then the last one would be crystalloid. That's one you want to use of absolute last resort. But if someone's blood pressure 40 and you literally have nothing else and you can't see it getting any better for some magical reason, I would give crystalloid, but I would be doing a lot of things before I did that. Okay. All right. Fully transfusion. Oh, what are those? Yeah. Transfusion transmitted disease. There we go. Fully transfusion transmitted disease tested, cold stored, low titer, whole blood from the Armed Forces Blood Program. That is the safest and most dependable blood source you are possibly going to find in the austere environment. Stored low titer, whole blood is the preferred resuscitation product given to you by the Armed Forces Blood Program. Okay, so the blood that your unit gets, that's what you should be using first. Okay, don't spin up a walking blood bank with non-pre-screened donors when you got blood in the flipping fridge, dude. Okay, so just so we're all clear on that, that is the resuscitation fluid of choice for trauma. Right. It can be stored 21 days in CDP, citrate dextrose phosphate, or 35 days in citrate phosphate dextrose adenine 1, CDPA 1. Okay, so you get a little bit longer in CDPA 1. Is it good the whole time? Is it good the entirety of that time? Sort of. It retains precipitously, but even at the end of its life, at the end of its shelf life, it will still retain some platelet function. Okay, and so it will still be better probably than partitioned product. All right. Patients, the CBG does talk about this. So because of the reduction in the platelet function in cold stored whole blood, all right, patients receiving massive transfusions, so many units, massive transfusion has a lot of different definitions, but receiving many units, those patients, if they're getting product that are older towards the end, the second half of their shelf life, those patients may benefit from fresh whole blood or platelet transfusion because of that reduced platelet function. So they're not, even though they're getting whole blood, right? They're not getting 1 to 1 to 1, right? Because the whole blood's not quite whole because the platelet function's dropping off towards the end of the shelf life. So consideration should be made to those people getting some pre-screened donor fresh whole blood or a platelet transfusion should you have it. All right. Other components, PRBCs, plasma, stored 42 days or 35 days in it's the DPA one, but and then plasma you can store as frozen, so frozen forever is what I called it, or never frozen. Can be stored and 26 days in CDP or 40 days in CDPA1. And then PRBCs can be stored frozen in glycerol cryoprotectant. They can be stored for like years, but when you have to thaw it and then like rinse the glycerol protectant off. Otherwise, it's like fatal for humans. And so that takes a long time. So you can't be like, I want a unit of frozen PRBCs right now. It's going to take like a while. All right. It requires special like equipment and special preparation. Okay. For plasma, if it's sort of frozen, all good. Okay. Um, you just thaw it out when you need it, and it can be stored for a very long time frozen. All right. Some people have advocated that if you might anticipate casualties, you could pre-thaw it, but then the lifespan is only 5 days after that. So if you pre-thaw it, um, you might have a lot of waste. Okay. Never frozen plasma, like I said, can be stored for 26 days or 40 days. But if you, but that's why we freeze it, 'cause it can be stored for, even longer. Okay. Freeze-dried plasma is becoming more popular. Should a big war in the future come out, freeze-dried plasma would be, certainly very popular, and it has been used. Platelets. It's kind of a low likelihood that you're going to have them due to short half-life, basically. Unless you're at a really big base with a really large, established, robust lab with a lot of our product capability, maybe you'll have them, but I wouldn't really anticipate having them because they do have a short half-life. Right. Okay, let's talk about type-specific whole blood or fresh whole blood. Okay, this is like walking blood bank. Okay? This is like freshly donated blood. This is an amazing asset. It is fraught with potential error. We're going to walk through the best, better, minimum guidelines that the CPG uses. Okay, there will be, a walking blood bank talk at some point. I've stolen parts of the walking blood bank CPG to discuss this in a semi-intelligent fashion. Just full disclosure, I've never done a walking blood bank. I did a walking blood bank training. I'll show you some pictures of that. and I transfuse things into myself, but not, I've never called for walking blood bank, had donors donate blood, and then use that fresh whole blood, just so we're all tracking. So you're learning from someone who's learned a lot about it, but has never actually done it. And there's not a ton of people who have that are certainly still in clinical practice, but you can find them should you look hard enough. All right, here is the best. All right, the best way to do this would be to identify group O donors pre-deployment with anti-A and anti-B titers below 1 to 256 threshold. Okay, this is what Ranger Regiment does. They identify their donors pre-deployment. This is what a lot of units are starting to do and have done for some time, to be fair. They're identifying pre-screened donors of their people who are O low titer pre-deployment and saying, if we need a walking blood bank, Ruiz, I'm coming to you. Smith, I'm coming to you. And Jones, I'm coming to you. You are my low O low titer donors. Okay. They are tested for transfusion transmitted diseases before deployment and every 120 to 90 days, 90 to 120 days. And then even then, you know what their blood type is, right? But you're going to confirm their blood type with an Eldon card or other approved means prior to donation and transfusion. Okay, we're trying to be as safe as possible. This is not FDA approved. Just red flag. All right, this is not FDA approved because these people, after their donation, are not automatically having their blood tested for disease. Okay, they're tested before. If you note that in the words right here. So that is the red flag with walking blood bank. That is why your hospital is not using walking blood bank. Okay, because this is not FDA approved for that reason, but it is well accepted. It has been done many times. Many units of blood have been given by this, but that is why. It's because the transfusion transmitted disease testing is done before you donate the blood instead of testing that blood sample after, which is what they do for like regular blood banks. Okay. All right. So that's the best. That's the best possible outcome. You pre-screen your people, you test them before, you test them for being low titer, you test them for diseases before, and then you keep testing them for disease. And then shit hits the fan, you need their blood. Hey, Ruiz, give me your blood. Cool. I'm going to make sure you're still O, even though I'm pretty positive you're O. Cool. You're still O to the blood. All right. All right. Better, it's better, it's minimum, better, best, and so better's the middle ground, which is kind of a weird. You're going to give type-specific whole blood from a pre-screened donor. So still, this person's pre-screened, okay? They're a group whatever now, because it's type-specific. They're tested pre-deployment. They are low titer, and they're tested for diseases before, okay? So they're a pre-screened donor, but now we're talking about A donors. Now we're talking about B donors. Now we're talking about AB donors, okay? O's going AB, sorry. A to A, O to O. So I'm a A donor. I'm going to give blood to A patients. All right. I'm an O donor. I'm going to give blood to O patients. And then low titer O whole blood to B and AB patients. Okay. I'm going to confirm their blood type before donation and transfusion. Group specific. So basically, when you're calling for donors in the massive, you're calling over the big voice. Hey, we need walking blood bank activation. We want all the Joes who are not actively defending the base, not fighting, come to me and we're going to donate your blood. I don't want some AB negative random dude. Okay. I don't want you. Go back on the wall. We don't want you. We want the O's and we want the A's. Okay. Those are the biggest groups. We want the O's and the A's. Ideally, pre screened. You might not know that in the joint environment. That's the problem. Where you deployed, there might be Marines there, there might be Navy there, there might be Air Force, there might be Army. You're an Air Force person, you speak Air Force, you don't know the roster of the Army unit that's coming to you. The Army unit out of Fort Riley, whatever, the 50 dudes come up and you say, hey, I'm pre-screened. Shit, dude, I don't know, maybe. Because I'm in the Air Force or I'm a Navy corpsman. I don't have access to your stuff. And so that's the problem. Pre-screening is great. Pre-screening is great, only if you can use it. Okay, that's the big rub. All right, so here's a minimum. This is what some people I think about when they think of walking blood bank. And obviously I'm showing you that there are echelons to this, right? This is best. This is what we should be doing, okay? This is best, and then this is minimum. But I think this was a lot of people think about when they think of walking blood bank, like the Wild West of just random dudes off the street, all right? When pre-screened donors from a low titer O whole blood or group-specific whole blood, read that as when pre-screened donors from low titer O whole blood, low titer O whole blood, or pre-screened donors from group-specific whole blood are not available. So we don't have pre-screened available people. That is when you're at the minimum standard, basically. You're going to identify these non-pre-screened donors with an Eldon card or other approved means. You are going to do it group to group, A to A, O to O, O to B, and AB. Okay? Cards to confirm their blood type. Okay? because you do these schmucks do not know their blood type, dude. Don't believe anybody when they tell you their blood type. So you both need to agree, which is now doubling the administrative burden. You both need to agree on what their blood type is. Okay, so you really need to be sure. All right. If adequate staff are not available, or you're in a chaotic situation, use group O donors only. Okay, so meaning it's going down, it's really hitting the fan. I got minimal staff. Okay, I'm done with group to group. All right. I'm only using group O people because I need a bunch of blood and I don't have a bunch of staff because they're all saving people's lives. I cannot be burdened with A and ABs and whatever. I'm only taking O donors. All right. Again, confirm the blood type. All right. With two people. There is a possibility of transfusion reaction if the donor is not titer tested. This is relatively low. Okay. This should not preclude you from doing this, but it is an acceptable risk, certainly in the opinion of the CPG writers, okay, which I agree with, right? People are dying in front of you. There's a low probability phenomenon that could happen. All contraindications are relative, and this is one that I think you need to consider that could happen, but you need to move past it. So, transfusion reaction secondary to not being low titer is possible, but it is of less severity and lower importance than an acute hemolytic reaction from an ABO mismatch, which is why you need the two providers, the two Eldon cards, which is why when it's chaos, you're only taking O donors only, so you really don't mix it up. You don't want to give an A and O and whatever. And so uh, if you have a titer reaction, fine. That's not awesome, but it's what usually generally way, 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 way less severe than certainly an acute hemolytic reaction, which can be fatal from an ABO mismatch. Okay? All right. Transfusion transmission disease testing. Utilize the rapid testing kits when pre-screened donors are not available. They're going to contradict that here in a minute. But when you have not pre-screened these people, dude, you don't know what they're doing on the weekend. Okay, you don't know what's going on with their life. So you're in the Wild West, right? You have no pre-screened donors. It's chaos, so you're only grabbing the O's. All right, if that's really what's happening, you're really working without a safety net for the safety of your patients. You really need to use these rapid transfusion transmitted disease testing kits. Okay, and what do they test for? It depends. It depends what your local area is, depends on what you have. Okay, so the priority should be made for HIV, hepatitis. Okay, those are big ones. And then diseases of local significance. Okay, like malaria would be an important one for sure. There are others, but you are in Africa, you're in Southeast Asia, maybe. You're taking blood from people. Nobody's taking their freaking malaria prophylaxis because nobody takes that, even though they should. And then you do not want to be taking a trauma patient who's been shot 5 times and you're trying to save their life with fresh whole blood and it's chaos. So you're, again, working without a net. You're using non-pre-screened donors and then you give them malaria. All right, so don't do that. So use your testing kits. All right, this is the second step in safety. Okay, first step is 2 Eldon cards. Second step is you're checking for, you cannot titer them probably because you don't have a lab and you just don't have time for that. So you check them for Eldon card, check them for Eldon card again, then you check them for transfusion transmitted diseases, HIV, hepatitis, malaria, whatever you have. That's what you should check before you're giving this blood. Okay. Even when, this is where they contradict themselves, even when with pre-screened donors, if there's adequate staffing and time, consideration should be given to transfusion transmitted disease testing prior to transfusion. Okay, the example would be there are dudes doing something, an hour away, and they get into contact. You have a report of casualties. They are transfusing blood in the field, but the casualties remain unstable. You have a very tenuous blood supply. You could choose then to tap one of your pre-screened low titer O whole blood donors. We're going to use Ruiz again. Ruiz, come here, bro. We're taking your blood. Okay, we're taking your blood. And then because of that, we have the time to test because their casualty is not going to be here in time. And so we have the time to test Ruiz's blood for transfusion transmitted diseases prior to that blood transfusion that we're going to give our casualty. Okay, so whenever you have the time, you should test. Okay, how are we going to store this stuff? Transfusion, how are you going to store type specific whole blood or aka fresh whole blood? How are we gonna store it? When you donate this unit, okay, so you donate a unit, you can store that for 24 hours at room temperature. If it's not used in that 24 hours, you got to throw it away. So you got to be like pretty high likelihood that you're going to use it if you're going to do this strategy. But if you're not sure, it can set out for a while. It can be stored at room temp for 8 hours, and then if not transfused, it can safely be refrigerated for its standard shelf life, depending on what it's stored in. Okay. All right. Here's some pictures of whole blood transfusion training. Okay, when you open your kit, down here on the left, it's gonna have all sorts of stuff in it. It's gonna have your donation bag. It's got some clampies. It's got some like alcohol swab. There's your Eldon card, some tubes. The normal saline does not come with that. And then here's my Medicare getting a good IV stick. Don't miss and don't mess it up because you can mess with the suction on the, sorry, the vacuum, I should say, on the bag. You don't really want to waste them because it is a big needle and you're sort of messing with the vein. It cannot just be stabbed over and over. And you donate your unit. All right, fill that bag up. So here's my blood in here, and then it needs to fill up. It has to be a certain weight, a certain like circumference. Usually comes with like a little string. Ideally you would measure it with a scale, because if it's too much blood in there, too little blood in there. If it's too much blood, it might be able to, might clot. If it's not, you get like a little citrate toxicity and problems. So you want to get the right amount of blood in there, honestly. And you don't want to under resuscitate your patient by giving them, 2/3 empty bag. And then you store your blood there, and then I was going to get access on my other arm, and we're going to donate the blood back into me, okay? And then you just donate that normal transfusion. So happy me, nothing happened. I did not, use a filter. Always use normal saline. You do not want to give blood without a filter. That's a huge no-no. So no, you don't take shortcuts, okay? But this is whole blood transfusion training, can be done. Your unit needs to prioritize this training, okay? Because when you really, really, really need it, you really, really, really need not to suck at it. Because like I said before, it can be super dangerous, okay? And so got to make sure that we're being safe. I'm type A, by the way, so I'm not in the chaos situation group. All right, some donor considerations. So usually only 1 unit of blood should be donated per donor. Say, give me 1 unit, get back out of here, go back to the line. And in extreme conditions, you have a small team. You got one dude who's a low titer O. Everybody else is some weird blood type. All right, that just sucks. Like you could consider an additional unit from that same donor, but then you have to evac them. Okay, consider evacing them, or at least keep them safe. Because should they get wounded, they're in deep doo-doo, right? Because you are taking blood off them. There are lots of articles talking about this 1 unit thing, and how it's probably fine. This one, in transfusion, is the journal. We're going to talk about transfusion later. It says 25 Norwegian soft soldiers. There was no degradation after 1 unit of donation. In this like skills thing that they did. They did some shooting. They did some like running. They did something else that I've forgotten. This is a common paper that's cited. These guys were Norwegian soft. You can give one and nothing happens after. This one, analysis of exertional safety after blood donation in active duty military personnel, feasibility study. Brandon Carius, EMPA, Beast. Mo Umar, Beast. I don't know, James Aiden, we'll just call him a Beast as well. And then Steve Shower, EM Crit Care, also Beast. He's been on multiple papers already that we've talked about. This was 25 U.S. Army soldiers. They had some small changes in their resting heart rate. Return to baseline heart rate was slower. And then the pre and post donation was a little bit. They said post donation things were harder in the patient's self assessment. In both of these studies, the patients served as their own control groups. So basically, what happened is they did the skills or they did the exercise, whatever, and then like a week later, they donated blood and they did it all over again after the blood donation. So this one said, hey, things were a little bit harder after that unit, but they were statistically significant, but not like crazy degradation in level. And this one this is in the Journal of Special Operations Medicine, April 25. This is a brand new one. This was 17 U.S. SOF operators. They had an increase in their shuttle run times. There was changes in their shooting score, and there was an increase in 8K run times. And so all differences were considered moderate, but they were all there. I mean, they were real. So like there probably is some degradation, but not so much so that you cannot actually draw a unit off these people. But should you were you to draw off 2 units, you probably would start to see really significant degradation. Okay, moving on to calcium. Calcium, falling over ad nauseum. All right, part of the deadly diamond of dying death. Go back and see that one. If you haven't seen that one, all right, go back to those earlier videos. The CPGs discuss 1 gram of calcium gluconate and 1 gram of calcium chloride at interchangeable doses. This drives me flipping wall. I've talked to multiple people about this because I've been giving 3 grams of calcium gluconate for a long time now. And I just wanted to confirm that I wasn't in Crazy Town, and I'm not in Crazy Town, according to the people that I talk to, of which I really respect, and probably should be running this channel, except I'm running this channel. Um, so these are not interchangeable doses, okay? The amount of elemental calcium and bioavailability of 1 gram of calcium chloride is like 3 times higher than that of calcium gluconate. So if you're given 1 gram of calcium gluconate and 1 gram of chloride, you're basically getting 1/3 the amount of chloride in the gluconate, okay? So you need to give 3 grams of calcium gluconate with initial blood product resuscitation, and then another after every 3 to 4 units, depending on which one you want to believe. But you cannot just be getting 1 gram of calcium gluconate and think you are repleting the calcium to a level that is on par with 1 gram of calcium chloride. It is just not. It's just not on par. So you either got to take the risk of the necrosis of the line or the vein or the skin necrosis, whatever, and give chloride, or you can get central access and give chloride, or you just give 3 grams of gluconate, which will require you to carry more stuff, but you'll actually be resuscitating them, appropriately. I think sometimes people think that like the calcium gluconate and the chloride might be the same, is because the the chloride often comes in 10 mLs, and the gluconate sometimes comes in 30 mLs. And so that's like a third, 1/3, or 3 times difference, but that's not, they're just 1 gram. They're both 1 gram. And then also calcium chloride come in, 10 mLs, and the gluconate come in 10 mLs. So if you're getting the gluconate, you got to give 3 grams. Okay. All right. TXA. We're on to hemostatic adjuncts. We are moving along swimmingly. TXA. To the hemostatic adjunct section, again, talked about exclusively. We're going to move past this. The very best, most favorable data for TXA says up to a 9% decreased mortality. Lots of other data is less rosy than that, but still probably positive. Okay, but this is the most aggressive data. It says up to 10% decreased mortality. Should be given within 3 hours of injury. Increased risk after 3 hours of injury. That's all we're going to say about TXA. Oh, just kidding. 2 grams TXA and 100 cc normal saline or slow IV push. Most places are doing slow IV push, but there is this theoretical risk of hypotension. It does happen. How common? I couldn't even quantify it for you. Have I personally ever seen it? No, I've not personally ever seen it. But in my, just for full disclosure, I don't work in pre-hospital medicine. They're all nice and fixed by the time they get to me. Just kidding. But oftentimes, where I live and work, San Antonio Fire is exceptionally progressive, and so they are giving TXA 2 grams IV push pre-hospital. And so, I'm not even giving TXA that often, to be fair. It's already been given. Okay, more hemostatic adjuncts. This is the abdominal aortic junctional tourniquet. I don't know if you've ever seen this before. This is like from their website. Compression Works is the company that makes this. This is in the CPGs. I'm not just throwing this out there. Again, I have no disclosures. I wish. So you can do junctional tourniquet here. They do abdominal tourniquet, and then they junctional like in the left inguinal here. All right, let's talk about this. So this was going to be like a lit review. There's not much literature to review. This is a direct quote from the CPG. This device, although not well studied, may be considered when the injury pattern suggests bleeding in the pelvis and or junctional lower extremities. What it basically does, it's a pneumatic device. It blows up an air bladder, and you put it on a junctional hemorrhage, or you put it on the abdominal aorta to occlude the abdominal aorta to prevent blood loss distally. Okay, blood loss from the legs or pelvis. All right. I tried to look up a bunch of stuff on this. There's mostly pig lab studies. There are some human case reports, but really not that many. Anecdotally, I know of a couple that have been used, like in quote unquote real life. Um, I don't know. The CPG is very lukewarm on this, and so like this advice is just not, it says right there, like not well studied. The manufacturer recommends a 30-minute max inflation time. Um, Bunch of the pig studies I found said that it like occludes the aorta and the venous system, and then it caused a bunch of like thrombus like after that. And so it's kind of like unclear where this should fit in your trauma algorithm. But it is in the CPG, so maybe talk to your medical director about it, decide where you want to be on it. Um, I would argue, or for me personally, it's pretty much not in my algorithm. But again, you work with what you got, and so I think it's nice to know that there are things out there when you're not sure what else to do. But when you're starting to occlude people's aorta, as we'll talk about when we talk about Reboa here in a minute, like you're getting into dangerous territory as again the smoke and mirrors person. Like I'm the smoke and mirrors person, dude. I'm not the surgeon. I'm certainly not the vascular surgeon. And so when you start to occlude people's aorta, you're really setting them up for reperfusion injury that you may or may not be prepared to handle. Okay. All right. So I don't know. Think on that what you will. Compression works, uh, abdominal aortic and junctional tourniquet. Cool. Let's talk about Reboa. Reboa's been coming for a long time. I've been wanting to talk about this for a minute, dog. So we're gonna talk about it now. All right. This is in the guidelines. Okay. Reboa is called the resuscitated endovascular occlusion of the aorta, is what Reboa stands for. It's in the CPGs and under hemostatic adjuncts. It basically says special people with special skills should be using these. And so if you're not special, keep reading. Move along, basically what it says. But it lets you know there's a thing. It says 30-minute balloon time for zone 1, which is basically an occlusion up here, just around the diaphragm area, and then 2 to 3 hour for zone 3. But we don't really know like the exact amount of time for zone 3. The CPGs keep it quite vague, and then they keep it quite short. This is what a Reboa looks like. So basically, this balloon sits in your aorta and it blows it up. It blows up the balloon with fluid, and then no blood flow goes distally. So you're preserving blood flow to the heart and brain. Then you're occluding distal flow. One of these is I think the white one is the port for the fluid, and the red one is an arterial line. So you could draw, like ABG from there. You can also transduce an A line for your monitoring. Okay, this goes in the femoral artery of the patient. This is where it goes. So it goes in the common femoral. Really important to get in the common femoral, and then it goes snakes up, the iliac. And this is zone 1 up here by the diaphragm, and then zone 3 would be below the renal arteries. That'd be like for pelvic hemorrhage, and then for zone 1 would be like abdominal hemorrhage. If someone has a chest trauma, chest hemorrhage, this is going to be a nice clean kill for you because it's basically going to create when you put your thumb over the hose, and you basically create a high pressure situation. That's going to create a high pressure situation. If you have an injury up here, it's going to just go pff, pff. So that's gonna be a nice clean kill. So if you blow that Reboa up and they instantly die, that's probably what happens. You missed a thoracic injury. Okay, what is the data behind Reboa? Why is it in a CPG? What's the data behind it? Is it any good? Should we be using Reboa everywhere? This is one of the biggest Reboa studies. This is called the UK Reboa trial. It was published in JAMA in November 2023. It's the big one. Okay, this is a big one. I don't know anybody on here, so I'm not going to give them shout outs, but I'm sure they're all great. All right, does Reboa work? UK Reboa trial, JAMA 2023, as stated previously, it's 90 patients in 5 years at 16 trauma centers. What is that? Over 1,500 days, and they found less than 100 people, okay, across 16 trauma centers. I assume that's like most of the UK. The UK is not that big. Most American states have 1 or 2 trauma centers, and so they have a lot for such a small area, but, I don't know. But in that amount of time, they only found 90 people. That shows you how tough it is to find somebody for some of these trials. The primary outcome, what were they looking for? Mortality at 90 days. And just some baselines of the patients. It was mostly men, all right, as most trauma papers are. High injury severity score, okay, pretty high injury severity score. These patients were all, and then almost all were blunt trauma. So sick, blunt trauma like car wrecks, falls, that kind of stuff. Here's a very interesting uh, graph that you get. It's usually figure 1 in most papers. It talks about the like enrollment. Okay. This is a really interesting one. And so this was 90 randomized people. The words are kind of small, so I'm gonna have to pause just to read these. 46 in the Reboa and standard of care group, and 44 were in the standard of care group alone. All right. 2 of the people in the standard of care group did get Reboa, and the balloon went up. Okay. Of the people in the Reboa plus standard of care group, 19 got arterial access, got the catheter inserted, and the balloon inflated. They got real Reboa. Okay, they got the intervention. So that's less than half. 9 had arterial access achieved, but the catheter was not inserted because the patient got better. 8, they attempted arterial access but couldn't get it. because the patients are sick. It's hard to get arterial access with sick people. 5 got access. The catheter was inserted, but the balloon was not inflated because the patient improved with standard resuscitative measures alone. So they got access, got the catheter in, unlike these people who did not put the catheter, but it didn't get blown up. 3 people, arterial access was not attempted because the patient improved regardless after randomization, and then 2, arterial access not attempted because the patient decompensated. They probably just died before. And so it's 90 people, 5 years, 16 trauma centers. You're talking about thousands and thousands of trauma activations. 46 people randomized to the Reboa group. Only 19 actually got Reboa. It's unclear, and plus these 2, so maybe 21. Okay, but they were not really in that group. So only 19 actually got. So we're basically making this decision of 19 people plus people who were in the control group. So not awesome, but again, like this just shows how difficult it is to do these trials. Okay, so I'm not shitting on these people. I'm just basically more lamenting or opining on the fact that doing original research is so damn hard. That's why I'm lazy and I don't do it, and I get to do this and just critique. But like, it's so hard to come up with high quality data, and because this is the data that we're working with, because it's just hard to get good stuff. Okay, that being said, this is about the best Reboa paper we can find. All that being said, it really is the best Reboa paper we can find. So, mortality at 90 days. This is their primary outcome. Reboa group, 54% mortality. Control group, 42% mortality. So like, this is high mortality compared to our like other trauma papers that we've seen, but very high mortality. Okay, way worse than Reboa group, 12%. Not only did they have higher mortality at 90 days, they had higher mortality at all other endpoints post-injury intervention. At 3 hours, they had higher mortality. At 6 hours, they had higher mortality. At 24 hours, they had higher mortality. Okay. Death in the Reboa group secondary to hemorrhage compared to the control group. We'll talk about why we think that might be. They talk a lot about posterior probability, and I'm freaking stupid, so I had to ask a friend about this. I said, explain posterior probability to me. And to my defense, I did Google it several times and couldn't quite get it right. The posterior probability is basically the probability that what you're measuring is causing the problem, basically. So in this study, 86% means that the probability that the cause of the increased dying is Reboa is 86%, essentially. The patients are dying. What is the probability that it is because of the thing that we're doing, that it is in fact the Reboa that is causing the dying? If that makes sense. Okay, there's all sorts of graphs. Again, I don't do graphs. My brain is like graph dyslexic. I'm much better just with words, and so that's what posterior probability essentially means. So that's all damning. Okay, that's all bad. All right, so it's all in the L column for Reboa. Skeptic's Guide to Emergency Medicine, freaking awesome website, awesome podcast. Listen to that if you're an EM for sure. Teaches you to be a skeptic and review data. This is directly from their website. There is no such thing as a free lunch in hemorrhage control. If you are spending time on one thing, you are stealing time from something else. The UK Reboa trial makes that point abundantly clear in a very uncomfortable way for trauma providers. This guest skeptic on Skeptic's Guide to EM was actually a trauma surgeon, okay, that wrote this article. And so this basically says that this increased death secondary to hemorrhage in a Reboa group is wild, dude. Like the Reboa occludes the aorta. There should be no hemorrhage. But the reason they talk about it in the journal is because we're messing around getting the Reboa instead of going to surgery, instead of doing other things. So if you're taking time from something, if you're doing something, you're taking time from something else. It's the opportunity cost of putting the Reboa in is costing you something else that you could be doing. Okay. You see this in the vascular access was even difficult. Okay, so like 8 arterial access was attempted but unsuccessful. Okay, and that's not, it's almost 20% of people, so 46 people, so 10% would be 4.6. So yeah, it's almost 20% of people they couldn't get access, right? And that's because, and these people in this thing, they actually did training. They did like significant Reboa training prior to the enrollment of the trial. So these people know how to get access. It wasn't that they just sucked. It's just hard when the artery is flat because the person's blood pressure is 50. It's just hard to get access. And so when you're futzing around trying to get access, you're not doing other things like giving blood, like going to surgery, etc. And so this is the last one, which I think really is an important point to make. This may be the biggest one, right? So I'm the smoke and mirrors doc. There's another doc there that really is the magician, though. And that's that trauma surgeon. the Reboa versus the standard of care group, time to surgery, 83 minutes in the Reboa group versus 64 minutes in the standard of care group. 20-minute absolute addition. Okay, and so like 20 more minutes until that person went to surgery, not in the Reboa group. So you think, well, I'm just going to throw in an A-line real quick and blow up the Reboa. Everybody who's been in, I'm just going to throw an A-line real quick room realizes that it's not quick, dude. It's not quick. It's going to take a minute. And so instead of doing that, you could have been opening their belly up and getting, direct visualization on that hemorrhage. And so I think that's a big problem when it comes to some of the Reboa stuff. There you go, UK Reboa. So overall, it's not great. It's not great for Reboa, but there are other papers. There are pro Reboa papers. So we're going to read one right now. Also in transfusion, this one's got some heavy hitters on it. All right, so Andrew Fisher, that guy's everywhere. Very experienced. Mike April, MD, PhD, soon to be program director at Brooke Army Medical Center, that's the alma mater. Julie Rizzo, Beast, Trauma, Burn, on a lot of stuff. So this is a big heavy hitter paper alert. This is the employment of resuscitative endovascular balloon occlusion of the aorta in deployed settings in transfusion. This is April 2024, so relatively new paper. It is retrospective. It is like all papers in the DoD, seemingly in the DoD trauma registry query. Okay, so it is basically they queried the DoD trauma registry data and looked for cases of Reboa. They looked for cases for like almost a 20-year time span, and they found 17 within 2 years. Those are the only cases that they found, all right, because Reboa is sort of relatively new-ish in terms of being used frequently. These patients were mostly male, mostly local nationals. This was all the deployed environment, by the way. 94% penetrating trauma, which is different than the paper we just talked about, which I don't even know if I actually wrote it down. I wrote almost all blunt trauma. The blunt trauma was like 85%. Okay, and so this is 94% penetrating trauma. So these papers are not related. Okay, the ISS, the injury severity score in this paper was much lower than the UK Reboa trial. And so these patients, although they had been shot or stabbed or blown up, there's a decent argument to be made that these patients in this transfusion paper are much less sick. Here's just some random facts. So, because this is not a trial, this is just basically a discussion of the cases. So 82% of patients just survived a hospital discharge. So that's huge, right? So like the Reboa group on the last paper, only like 46% survived. So a lot of these patients survived. Most of these patients survived. 88% of the Reboas were placed in the Roll 2, which is not usually the primary resuscitation area in the deployed environment. And then the rest were placed in Roll 3, so like 12% in Roll 3. 76% of them were placed in the OR, which is kind of interesting to me as an ER guy because I always think about me deciding whether to place a Reboa in conjunction with my trauma surgeon friend, right? But most of these are placed in the OR. About a quarter were placed in the ED. Large percentage of these casualties met massive transfusion thresholds. So people were, although I said they were less sick than the other people, they were still sick. I don't want to minimize their sickness, their war casualty sickness, but they were sick. Several patients needed fasciotomy and or open vascular repair. Here's the critiques of this one. So it is unclear if the fasciotomy that the patients received or the arterial repairs were from injuries or complications of the Reboa, meaning did the person get shot through their artery? Did they have explosive fragmentation fly through their vascular system? Or did they need arterial repair and or fasciotomy from complications of the Reboa itself, meaning I put a Reboa in and I actually placed it a little too distal, and now I have an occlusive phenomenon in the superficial femoral artery or the deep femoral, or I'd like injured the artery in some way that required an opened arterial repair. If you have an arterial occlusion, you can cause a fasciotomy due to distal limb ischemia. And so is this from the injury or from the intervention? It's hard to say. This is the problem with retrospective data. You just don't know. The median age in this study was 20 years younger than the UK Reboa trial. I believe the average age in the UK Reboa trial was like 41, and the average age was 20. And so these people were 20 yeyears younger. Okay, so and then the UK Reboa trial patients had a much higher ISS, and so these patients are not like directly comparable, but the differences are quite massive in terms of the outcome and the patient population. In the trial, they talk in the paper they discussed this. Sorry, they openly discuss this and say, these patients were much younger, much healthier, most likely, even though, I would argue they're probably not as healthy as, let's say, the average 20-year-old in the UK, or average 20-year-old in Canada, United States, or Mexico, because they were living in a conflict zone, and so they could have higher disease burden, regardless of that. Um, this is my last critique. So some of this, there's a lot. Every time you're writing a paper, you cite other papers, right? We're doing this paper based on these previous findings, blah blah blah. Many of the studies cited in this paper regarding pro-Reboa outcomes had outcomes that I would argue are not patient-centered. They had outcomes that I would argue are Reboa-centered, but maybe not patient-centered. And for example, some of the papers had outcomes like this. Did the patient survive to the next echelon of care? That was the big one. And one of them, in a particularly egregious one, that really pissed me off. And again, I'm just here to critique, right? I don't do original research, so I'm not saying that those people shouldn't be publishing that. I think they should, if we got to survive to 90 days, if we're going to survive to 90 days, we got to survive to the next echelon of care, certainly. But that's less important than surviving 90 days. And so we shouldn't really claim that surviving to the next echelon of care means that we should be employing Reboa aggressively. All right. That being said, this is a very pro Reboa paper for the most part. 82% of these people survived and they got Reboa. And so, like, as a temporizing measure for these people, it certainly worked. Goes in direct contrast to the other paper that we talked about, but they're in different environments. As we said, they're not the same patient populations. Here's my bottom line. I'll stop, just meandering and whining. Reboa is a thing. It's a real thing. You need to learn about it. You probably need to learn how to do it, or at least how to conceptually do it, or bring it up to someone who knows how to do it. The exact patient that it is best for is probably still unclear. It is very hard to give like full-throated recommendations of Reboa given the current evidence. But would I place Reboa in the austere environment as an attempt to temporize a hemorrhagic shock patient as a bridge to surgery? Yeah, dude, like I totally would. I would totally not let someone die in front of me with an injury that was amenable to Reboa if I had attempted other means that had failed. Okay, I definitely think that there's a firm position for Reboa. I have a surgeon. That surgeon's tied up right now. They will be untied up in a brief moment, and I have a decompensating high inguinal GSW, not amenable to direct pressure, wound packing, junctional hemorrhage control, and the person's dying. And I have some blood, but not a ton. My surgeon's going to be done in 15 minutes. I'm yelling at him, get your ass out of the OR. I'm putting a Reboa in, and then this guy's the next patient back. I think that person definitely needs Reboa. I think that's very reasonable. Should all trauma patients who have hemorrhage be getting arterial access in preparation for Reboa placement? I think definitely not. That would be certainly a bridge too far for me. But I think there is a person out there who Reboa is good for, as one of the papers showed. But I think that was a very limited data set, 17 people. The previous one before that, only 90 people, 46 in the control group, 46 in the intervention group. And of those, only 20, 19 or whatever got the Reboa. And so we're making these decisions on really limited quality data. But it is the best data we got. Love this meme. Favorite Reboa meme I found. It's this guy who doesn't know what to do. Should I push one button or the other? Is it the get the absolute basics right the first time button? Or is it the I'm going to do the cool, expensive thing with no proven benefit? I would argue the Reboa is the cool, expensive benefit with no proven benefit. And the fundamentals of March, TCCC, damage control resuscitation, the deadly diamond of dying death, all that stuff is on the left, the absolute basics, things that we know work. Okay, so where should we put our money? Up to you. All right, we're in the final third. I know we're going over. But again, time is a construct, so it doesn't matter. Monitoring is supposed to be vital signs, urine output, not up. Sorry, it's a typo up there. Labs. Continuous monitoring is critical for the evaluation of resuscitation endpoints. How do we know when to stop if we don't know why we're stopping? The minimum is you got to check their mental status, vitals every 15 minutes, and then every 30 minutes to 60 minutes once they're stable for more than 2 hours. Better is that stuff, plus capnography, ideally with a waveform. And then best is real-time portable continuous monitoring with waveform capnography. Okay, so if you have a monitor, dude, you should definitely be breaking that sucker out and using it. There we go, got it right in that one. Urine output, the goal would be greater than 0.5. The CPG has this weird anecdote. They say If you're using a Nalgene, you should fill that Nalgene up, and it's 180 milliliters every 6 hours, which is certainly more than 0.5 milliliters per kg per hour, I think. And so 0.5 milliliters per kg per hour is really sort of a standard baseline for most people. A normal person's being more than that, certainly, but yeah, you can use a graduated cylinder, use an Nalgene. The best one is a Foley catheter with continuous urine output, checked hourly. So laboratory evaluation, the minimum is you don't have any, so none. The better is you have point of care lactate. If you have point of care lactate, you probably have other stuff like a DBG and stuff. So the best would be lactate pH base deficit, hemoglobin and hematocrit, and an INR Q60 minutes and then after they stabilize, sort of Q6 hours. And then, so something that we're trying to decide is like, what bucket does our patient go into? All right, so we have the sick or not sick bucket, right? If we're talking about D3R, they're sick, right? We've already selected them into the sick bucket. Then we start doing stuff. The stuff we're doing, is it working? Are they a responder, meaning we do stuff to them and they get better. Their blood pressure gets better, their heart rate comes down, they stop sweating, they become more conscious, they're better. All right, sweet, they responded, awesome. Are they a transient responder? They were sick, they got a little bit better, then they got sick again. This is a dangerous patient, okay? This is a dangerous patient. You could walk away from this patient. You can start to reprioritize this patient as a lower priority and start taking care of more sick people. And then this patient could decompensate sort of secretly. Transient responder should really prompt you to have a reassessment of your hemostatic procedures. Is their tourniquet still good? Is I converted the tourniquet to a pressure dressing? Is that still good? Or are they actually bleeding to death through that? It should lead to an assessment of acidosis and hypothermia. Like, is this patient cold now? Are they actually getting hypotensive? Are they getting acidotic? And they were sort of normo pH, and now they're acidotic. They were occultly sick, and I missed it. They should have a trial of repeated resuscitation, meaning additional blood products. Get them on a Bayer hugger, on a warm blanket, something, and a reassessment of their blood stuff, their hemorrhage control. Some of these patients will have sort of slow, non-compressible hemorrhage in the abdomen, potentially. That if you have continued resuscitation, you could keep up with that blood loss, but they're in danger of becoming a non-responder, certainly. So non-responder is they do not respond to resuscitation. They are sick as hell. You give them stuff, it does nothing. Okay. It's really scary to be doing things. It's very anxiety provoking as a physician or as anyone who's going to take care of a sick person. You're doing things, you're throwing the kitchen sink at them, and they just seem to be dodging the kitchen sink. Okay, they're not getting hit by it at all. All the blood you're giving is just basically dumping out into their chest tube, or all the blood you're giving is just making their abdomen distended. Maybe they have a retroperitoneal hemorrhage or intra-abdominal hemorrhage, and they're just not a responder. So before you declare someone a non-responder, you need to just make sure they're really not bleeding from anywhere. You don't see any external source of bleeding that you can do anything about. You have checked and rechecked all the previous procedures that you've done for them. The IV is not, his tube is hooked up to suction. Both sides of the chest are decompressed. You should assess for pericardial tamponade. If they don't have that, then you're in trouble. Okay, that person's in trouble basically if they're in a non-responder category. If the major bleeding cannot be controlled, it's unlikely that the casualty will become a responder. You might be in a situation where you declare, continued resuscitation futile. You'll have to make a tactical situation and saying, hey, look, I got 10 units of blood here. I got 5 casualties. I've already dumped, a third of my blood into one person, and I know I'm going to have some surgical casualties. And this person's, they came in peri-arrest, they remain peri-arrest despite massive effort. They may need to lay down their life for the service of the others who have blood and other things that they need. Okay, it's a difficult decision to make. We'll talk about that going forward. DCR endpoints. When are we going to stop? The minimum. They get better. Okay, their physical exam and vital sign findings show that they're getting better. Okay, they get a slower heart rate, palpable peripheral pulses now, where they were not palpable previously. They have brisk cap refill. They're warming up. Their mental status improves. You saved them. Strong work. Better is the systolic 100 or higher if they're getting blood products, if they have TBI greater than 110. If no blood products, if they're an interesting one in there, 80 to 90 if no blood products. I can see that, right? You don't have blood products, let's say. You have some crystalloids, but you don't want to give that, and their blood pressure sitting around 88. Mental status is okay, fine, hold off. If they start to get low, you may have to pull the trigger on something else, but an oxygen saturation of at least 90, ideally an FiO2 less than 50%. Which is funny. They talk about that FiO2 less than 50%. They don't talk about anything about intubation, ventilation, or anything like that in the CBG, but they threw them there right at the end. Temperature greater than 95. As we've talked about in hypothermia, that's low, dude. That's too low. Okay, they need to be normothermic. All right. We talked about that in the hypothermia CBG. Basically, 97 is too low. All right. I think that was Shower in April again that looked at those endpoints. In basically 97 is where you start to see an uptick in mortality when patients are getting hypothermic, which 97 is like almost everybody. Then urine output greater than 0.5 milligrams. Sorry, that should be milliliters per kg per hour. Another typo. Second typo by me. Sorry about that. And it should be urine output UOP. My bad. And then best. Best would be all that plus labs showing their hemoglobin is above 8, which 8's low if you know hemoglobins. And then lactate less than 2.5. If you have a hemoglobin of 8.1, and you're probably not going to have a lactate of less than 2.5 if you're a trauma patient. But anyway, base deficit less than 4. Okay, pediatric considerations are basically peds considerations, expectant management, and then we're done. All right, this one sucks, dude. So kids die in war. Kids die in real life. If you work in a hospital long enough, you're gonna see some dead kids. That just sucks. Um, all your training, all your life training before that will not prepare you for that completely, but hopefully it will give you at least some resiliency to be able to continue working after you see this. But if you go to combat operations of any significant value, you're going to see dead children most likely. So you need to wrap your brain around that and prepare for that eventuality. They may be in your rules of engagement for medical, they may not be, but it doesn't mean people will not bring dead children to your base. All right, so you need to stand by and be prepared for that. And at least, here's the problem: when something in your brain doesn't meet the reality, that's where there's conflict. Okay, if you know that dead children could happen and you see dead children, that will be less bad for you than if you don't think you're ever going to see a dead child and then a dead child shows up on your doorstep one day when you're working. All right, so you need to at least wrap your head around that this could happen. Failing to prepare for these casualties is failing to prepare for a large percentage of your casualties in terms of large scale combat. Yeah, that's just the truth. As discussed in this paper in Injury, July 2021. I don't know any of these people. Pediatric casualties and contemporary armed conflict. I was basically looking for what percentage of casualties are kids. All right, I need to discuss it now in the show notes. So this was a study looking at military treatment facilities in Iraq and Afghanistan, admitted for blast injury. U.S. military treatment facilities in Iraq and Afghanistan, 2002 to 2010. 25% of all the civilian patients admitted for blast injury were under the age of 15. So this is going to be a massive amount of people that you're seeing are going to be children. Children are particularly prone to war trauma. They're small, they're vulnerable, they do not make good decisions. Their parents are potentially dead, injured, fighting, fleeing, whatever. Children are potentially vulnerable to all scourges of the earth, war, famine, disease, and so war, who knows, maybe being the worst among those because it is almost always preventable, but large percentage of your patients could be children. Pediatric considerations. The CPG specifically discussed that military treatment providers may be at a particular disadvantage when it comes to treating pediatric patients because we are not used to treating pediatric patients very often in our MTFs. So that's something to consider. Think about PEDS patients. They also talk about smaller circulating total blood volume. Okay, like I have a lot of blood inside my body. All right, so if I lose a unit of blood on the floor, it looks bad, but if a 1-year-old loses, that's a huge problem. Okay, so underestimation of the blood loss is likely to happen for us. The example is a 1-year-old has about 2 unit total body blood volume. So, they have an amputation and they lose, 1 unit of blood. They're already basically, they're going to be peri-arrest. Typical RBC transfusion is 10 to 20 mLs per kg, same as FFP. Depending on how big or small that person is, it may be easiest to push-pull. Basically, you pull blood out of that bag and then you push it with the syringe. If they're 6 or 7 years old, maybe you can, transfuse a certain amount through a pressure bag or something, but it will be hard to judge. All right. In TXA, there is doses for TXA for kids, 15 mg per kg, max of a gram, and then they're not on the 2 gram bolus, obviously. And then infusion of 2 milligrams per kg per hour for 8 hours, probably up to another max of a gram. Right? Children are at high risk for hypothermia and metabolic derangements of trauma. Somewhere I had read something about total body surface area is high in kids, right? And then the metabolic derangements of trauma are just significant in children. Then when it comes to infants, they have like certain nutritional needs that other children don't have, and so it's complicated. All right, it's basically complicated. Your training should include some pediatric considerations, especially I don't, there's kind of many soft operators, but if you're an 18 Delta or you're in civil affairs, um, you could be in a situation where you really are dealing with children because you might be the face of the whole of America in a country that we're not even in at a significant established basis or anything like that. And so you will need to be a jack of all trades and be able to take care of children. Okay, expected management. This is tough one, but we do need to think about this as well. So as discussed in the non-responders, sometimes further resuscitation is futile. Like we just keep doing things and it's pointless, right? Everybody, people working in healthcare have probably been in a cardiac arrest where like the cardiac arrest is going on for an hour and like we just keep shocking them and then they go back into a non-shock rhythm and go back and forth, back and forth, back and forth. It's like it's been 90 minutes, dude. Like we're not getting this person back in any meaningful way. So at some point in time, you just have to call the code. This is similar to that. So um, there are certain like just non-survivable injuries, tactical considerations, and operational constraints that resuscitation leaders need to consider stopping aggressive efforts. So every effort should be made at getting contact with higher medical control. So don't forget to phone a friend, right? You have upper echelon people you can talk to, teleconsultation, that kind of thing. Feel free to call a friend. I would definitely do that before I basically, if you're a non-physician, declaring someone expectant or not, haven't received, maybe significant training in that. Stopping aggressive resuscitation efforts does not mean stopping efforts to ease pain and suffering. Just because we're not going to give them 10 more units of blood doesn't mean they don't get pain control. It doesn't mean they get anxiolysis. All right? It doesn't mean, we don't splint their limb, let's say. So it doesn't mean those things. It doesn't mean we don't keep them warm. It doesn't mean we don't keep them out of the elements, right? Get them out of the flipping rain, like, that kind of stuff. Just because they're expectant doesn't mean we stop caring for them. All right. Here are some injury patterns that are consistent with probable expectant management as the appropriate modality. Big list there. Okay, so like massive TBI with exposed brain matter and signs of herniation. Okay, uh, big penetrating chest abdominal trauma with non-responders after multiple units and chest compression. Sorry, that should be chest decompression with assessment of pericardial tamponade. Um, Junctional amputations with pelvic disruption, out of hospital cardiac arrest. They got some weird rules in here, like despite bilateral decompression. CPR longer than 5 minutes, like shouldn't really begin CPR and out of hospital cardiac arrest. That's traumatic. Then they write asystole or wide complex rhythm. So I guess the only one that like PEA, like I don't really know why that was on there. And then C spine injury with cardiovascular collapse. Like, well, I don't know if they have a cardiac arrest. You may or may not know they have a C spine injury. Maybe they have like penetrating C spine injury with cardiovascular collapse. Like obviously they have cardiovascular collapse if they have a hospital cardiac arrest, and so then of course decapitation and thoracopelvic disruptions have basically been like sliced in half. These are all horrible things to consider, but they are out there. And then of course non-responders. All right, I think that's the end. We made it. Longest one yet. We're at an hour and 24 minutes. We're watching on 1.5, so basically at 45 minutes. We can keep going. We're going to reread the goals of DCR again, wrap it up. The major principle of DCR is to restore homeostasis, prevent or mitigate the development of tissue hypoxia, oxygen debt, and burden of shock, as well as coagulopathy. This amounts to preventing blood failure, specifically with a goal of restoring blood functionality, improving oxygen delivery and tissue perfusion, reducing acidosis, preventing fibrinolysis, reducing coagulopathy, protecting the endothelium, and reducing platelet dysfunction. Okay, that's what we just did. That's what we just learned about. We're going to do it by all these things. We're going to give aggressive hemorrhage control. We're going to give a blood-based resuscitation strategy. We're going to avoid or limit the use of crystalloids, selective use of hypotensive resuscitation, correct coagulopathy and acidosis, avoidance of hypothermia, and expeditious evac to a DCS capable facility. Sweet. We made it to the end. Capstone CPG, DCR in the prolonged field care environment, some of the blood ones. It's a big boy. I don't know what the next one's going to be, maybe some blood stuff. But this is really an awesome one. This is one that we really start to put it together. And so you make it through this, you start to understand it. This is why we're doing this stuff. Damage control resuscitation starts at point of injury. It goes through the initial hours of the casualty journey through the echelons of care. I believe that whoever touches the patient first may have the biggest impact on their survival. And if that's you, you have the responsibility to not suck. TCR joins all the lessons of March, leadership, and team dynamics to provide what critically ill wounded need in the initial stages of trauma. Okay. And then this is the same, whether it's military or civilian trauma. There's no difference. Okay. You take a rural trauma casualty, they have the same logistical problems as a combat casualty in the deployed environment. They are no different. Okay. They have potentially inexperienced providers working for them. They have non-trauma providers working for them. They have evac restrictions due to weather, due to just regional problems. Now I'm over a mountain range. I can't fly a helicopter over that mountain range because I live in Colorado or I live in wherever. They have the same problems in military and civilian trauma. So if you are not in the military, this video is nothing for you. This is the same. The problems are the same. Okay, we're at the end. Again, shout out to this is going up on YouTube, obviously. Stolen Valor Medicine, whopping 4 subscribers. When I took that picture, there's probably 20 now. So we're not getting rich, but feel free to spread these out far and wide to any single person who would ever want them. Again, don't send them to your prepper dad. But if you know a firefighter, paramedic, police officer who's had some training in medical, and certainly any military medics, this is for them. Um, I always end the videos like this. So trust your gut, do your best, be a good teammate, and always stay in the fight. Keep learning about these videos. Keep on the next one. It'll probably be some blood stuff, but I may get burned out on some of the trauma stuff and may move to maybe we'll do burn or maybe we'll do snake bite or something kind of fun. All right. Thanks so much, guys. Feel free to share them far and wide for me. Here's the sources, the CPGs, a bunch of other like direct ones, and then all the listed journal papers, certainly. All right. Cool. See you guys next time.